All right, let's dive right into a really fascinating medical case. We're talking about pheochromocytoma, which is basically like having a secret rogue factory inside your body that's gone completely haywire.
You know that feeling, right? That jolt of adrenaline when something startles you, your heart starts pounding, you're suddenly wide awake. Now just imagine for a second, what if that feeling never turned off? What if your body's emergency alarm system was just stuck on? That is the exact reality we're going to explore.
So, like any good medical mystery, this one starts with a puzzle. And for pheochromocytoma, it's this really specific and pretty alarming set of symptoms that can seem to come out of absolutely nowhere. It leaves doctors and patients trying to piece together the clues. And those clues form what's known as the classic triad. We are not talking about a mild headache here. Patients describe these sudden, crushing headaches that feel like they're being hit by lightning. We're talking about sweating so intense it soaks through their clothes, and a heart that feels like it's literally trying to hammer its way out of their chest. You can imagine how terrifying that would be. To keep this straight, there's a really handy mnemonic that doctors use, the 3 Ps. First P is for pressure, and we mean dangerously high blood pressure. The second is for palpitations, that racing, pounding heart. And the third is for perspiration, that crazy, intense sweating. That triad is a massive clue. Okay, so what in the world is causing all this chaos? It's time to pull back the curtain and unmask the culprit, to find the source of all that runaway adrenaline. And here it is, a pheochromocytoma. Now that's a mouthful, but it's basically a rare tumor that grows from these special cells called chromaffin cells. They're usually found in your adrenal glands, which are these little glands that sit right on top of your kidneys. And the problem is, this tumor's one and only job is to pump out massive, uncontrolled floods of adrenaline-like hormones called catecholamines. Honestly, the best way to picture this is to think of a rogue adrenaline factory. It's supposed to be quiet, only working when needed. Instead, it's running 24/7, just churning out these powerful hormones and flooding the body with way more than it can handle.
So here's the chain reaction of chaos. The tumor just blasts out these hormones. They grab onto all the adrenergic receptors in your body, the very same ones that get triggered in a normal fight-or-flight situation. But because it's such a massive overdose, the body gets thrown into this state of permanent overdrive. And the result? Sky-high blood pressure, a dangerously fast heart rate, and all sorts of other metabolic problems.
So, once doctors suspect this is what's going on, the next phase begins. And it's like a high-stakes investigation. They have to turn into detectives and hunt for this tiny, hidden source of all the trouble. I mean, that's the million-dollar question, right? This thing is often super small and tucked away deep inside the body. So how do you prove it's even there, let alone pinpoint exactly where it is? Well, the approach is really smart and logical. It's a 2-step process. Step 1 is all about biochemical confirmation. So before they even start looking for the tumor with scans, they have to prove with blood or urine tests that the factory is actually overproducing. Step 2, only after they have that proof, is localization. That's when they bring in the imaging to find its exact hiding spot. And the absolute best way to prove that overproduction is by measuring something in the blood called plasma-free metanophrines. Think about it like this. The catecholamines are the factory's main product, but they break down really fast. The metanophrines are the leftovers, the byproducts. They're like the factory's exhaust fumes. They hang around in the bloodstream for much longer, giving off this clear, undeniable signal that the factory is running when it absolutely should not be. So once the tumor is found, it's time for the final act, the takedown. But this is no simple surgery. This is a super delicate, high-stakes procedure where the prep work is literally everything. See, the only real way to cure this is to surgically remove the tumor. But just going in there can be incredibly dangerous. The surgical team has to play this very careful, strategic game of chess with the patient's body chemistry to make sure everything stays stable during the operation. This is the protocol, and you absolutely cannot mess with the order. First, the patient gets an alpha blocker. This medicine helps relax the blood vessels to get that wild blood pressure under control. Then, and only after the blood pressure is stable, they can be given a beta blocker to slow down that racing heart. Medical students learn this rule with a very stark, very memorable saying, alpha before beta, or the patient will meet their creator. I know, it's dramatic, but it hammers home a principle that is truly a matter of life and death. Getting this sequence wrong can be catastrophic. So let's look at why that order is so critical. If you give the beta blockers first, You end up with something called unopposed alpha stimulation. Basically, all that adrenaline in the system now only has one place to go: the alpha receptors, which cause blood vessels to clamp down hard. The vessels constrict violently, blood pressure shoots through the roof, and the patient goes into a hypertensive crisis. But if you follow the protocol correctly, the vessels stay relaxed, blood pressure is controlled, and the patient is stable and safe for surgery.
All right, so now that we've walked through the diagnosis and treatment, let's kind of zoom out because pheochromocytomas have some really interesting patterns, and they're often tied directly to a person's genetics.
For a really long time, this tumor was known for the classic rule of 10. It was this handy little memory aid for doctors to recall its key features, although, as we'll see, some parts of it are a bit outdated now. So the old rule went like this. About 10% of them are bilateral, meaning in both adrenal glands. 10% are extra-adrenal, so they're found outside the adrenals. 10% are malignant or cancerous, and 10% are found in kids. The rule also used to say 10% were familial, meaning inherited. But here's the update. Thanks to modern genetics, we now know that number is way higher. It's actually closer to 30 or even 40%. And speaking of genetics, these are some of the heavy hitters. Syndromes like MEN2, von Hippel-Lindau disease, and neurofibromatosis type 1 all carry a much higher risk for developing a pheochromocytoma. This is why finding one of these tumors almost always kicks off a genetic investigation for the patient and sometimes their whole family. And here's one last really cool detail. When a pathologist actually looks at a slice of this tumor under a microscope, they see a very specific, unique pattern. It's called a Zellballen pattern, which is German for cell balls. You can see the tumor cells are grouped together in these little nests. It's a dead giveaway, a histological signature for this tumor.
Okay, let's do a quick fire review of the absolute must-know facts. The classic triad: headache, sweating, palpitations. The single best test to order: plasma-free metanephrines. The absolute unbreakable rule for surgery: alpha blockade before beta blockade. And that signature look under the microscope: the Zellballen pattern. Got it?
And we'll end on this thought, which is just pretty wild to think about. Isn't it just amazing how one tiny group of malfunctioning cells can completely hijack the body's most powerful primal survival system? But what's maybe even more amazing is that through science, chemistry, and strategy, medicine figured out the playbook to take down that rogue factory and give control back to the patient. It's a perfect example of the incredible battles being fought and won inside our bodies every single day.